All right. Hi, everyone. Welcome to our closing keynote panel, and incredibly excited to get to have a discussion today with Dr. Brian Caveney. He comes to us as part of our Dean Speaker Series. This is a series hosted by Dean Doug Shackelford and the Frank Hawkins Kenan Institute of Private Enterprise. The series is made possible through the generous support of the Archie K. Davis Endowment, and it was created to bring outstanding scholars and leaders from the fields of business, education, and government to share their thoughts and insights with UNC Kenan-Flagler, the university, and the community at large. Our speaker certainly fits that kind of objective today. It's LabCorp President and Chief Medical Officer, Dr. Brian Caveney. Brian has broad responsibility at LabCorp for medical and scientific strategy, including serving as primary medical representative of the company externally, defining global standards for medical and scientific activities across LabCorp's diagnostic and drug development businesses, and enhancing a culture of medical and scientific excellence. He's the past president of the Southeastern Atlantic College of Occupational and Environmental Medicine and continues to hold an active law license in North Carolina. Brian came to LabCorp after serving as Chief Medical Officer at Blue Cross Blue Shield of North Carolina. And he also served there as Chief Clinical Officer of Mosaic Health Solutions, a wholly owned subsidiary for strategic investments in diversified health solution businesses. Before Blue Cross Blue Shield, he was a practicing physician and assistant professor at the Duke University Medical Center, as well as working as consulting services across a number of companies in the Triangle. He has an MD from West Virginia University School of Medicine, a JD also from West Virginia University School of Law, an MPH in Health Policy and Administration, thankfully from the University of North Carolina here at Chapel Hill, and he did his residency at Duke, is board certified in preventive medicine, specialty in occupational and environmental medicine. So if you think about kind of how do we pull together all of the threads of what we discussed today, we bring in someone who's now a leader in the testing business. Prior to that, a chief medical officer at a payer, has been a practicing physician, so an incredible background. With that, Brian, thrilled to have you here.
Well, thanks so much, Brad. It's great to be with you and all of the attendees. I look forward to this conference every year and have come religiously for many years as an attendee and participating in a few ways. It's always a great way to bring many different disciplines together and discuss the issues of the day. And there might be one or two things going on in healthcare today, as you've evidenced from the really, really good panels that have taken place already this morning.
Yeah, and so for the audiences, we were talking about how best to structure this. We decided that doing it as a fireside chat, and in particular, really thinking about the themes that have come up throughout the day. And so we've had, Brian has been kind enough to sit in on our panels as well. The team has been feeding me questions in addition to seeing things myself. So we will, as before, I've got more questions than we could fill or than we can get through in our time. But to the extent you have additional questions, please include them in the Q&A, and I will work in as many as I can. I want to start with, not shockingly, COVID, Brian, and certainly you have been on the frontline role. I remember you joined me in a class in February, and we were talking about kind of how it was kind of growing. Could you talk a little bit about how kind of the ramping up of COVID testing in the US was so challenging?
Absolutely, Brad. And I can, there's so much Monday morning quarterbacking going on right now, and it will be for years to come because there's so much more we know now and can go back and fix, get ready for the next thing, continue to address what we have. But it was so challenging in the early days, as you mentioned, because there was tremendous uncertainty at the time. I would say at LabCorp, which many of you know is headquartered right here in North Carolina, just west of the Triangle, we're very lucky in the sense that we're a global life sciences company, and we have a few thousand people in our clinical research unit west of Shanghai, not that far from Wuhan. So we actually had a very inside look very early on in our need to protect the health and safety and welfare of our own employees that were working in the Chinese provinces and were aware of things happening well before maybe even the global media. We're also very lucky in the fact that, we're a very high volume infectious disease testing organization, have been for many, many decades. Our head of virology has been on the CDC's emerging pathogen disease committee for many, many years. And we were right in the center of, Zika virus and H5N1 and H1N1 and Ebola and multiple other things, both building the diagnostics as well as being on the front end of the science. So we were literally in as good a position as you could possibly be for having some semblance of what could possibly happen, but yet still there was so much incredible uncertainty at the time. We did work with the CDC very closely through February as they were doing their own sequencing from positive specimens they were getting from Wuhan, China, because you have to have the RNA sequence in order to be able to very specifically identify the pathogen. As you and the attendees know, there are many other types of coronavirus. There are many other types of virus. You have to be incredibly precise in identifying this particular one versus others in the equipment. In the early days, we're a very high volume viral testing organization. We were one of the early pioneers in PCR technology, which, as many of you have seen the media, that's the primary technology being used for the most accurate diagnostic test for this. We've been doing that for over 30 years and have that equipment all around the world. But yet, as you can imagine, trying to be a very responsible, efficient organization with our resources, it was all essentially in use for clinical testing taking place. We do lots of HIV and hepatitis and women's health organism identification using all of that equipment. So switching it over is not as easy as just, having equipment sitting around in a warehouse that you can turn on and be ready to handle pandemic volumes of testing. So as you can imagine, and then of course, the equipment itself is just one of many, many things that have to be right in order to do it. From the IT interfaces, having the regulatory ability to actually offer a test in the market and working with the FDA, having all of the consumables required to do the testing. So the liquid reagents, which are the primer sequences that are used for identification, the simple things like the plastic pipette tips, the well plates, all of the other things, and importantly, the labor required to do it, that know how to use the equipment and can efficiently handle the specimens safely in transport. And so in that first week of March, we were fortunate to be the very first commercial lab to be able to offer the test to the public after the original CDC assay. But even though we're a very large, efficient organization, we could only do a few hundred specimens per day. And I'm actually sitting in Burlington, North Carolina right now, looking out my window at the single largest clinical laboratory in the world under one roof right here in North Carolina. And one building has probably done more tests than any other on planet Earth since the beginning of this, specifically for COVID-19. But yet it was very challenging to scale up in those early days, literally a 24/7 endeavor for about a month to handle all of those different issues that I just mentioned, to be able to scale up. And now across our whole footprint, just in the US, we can do somewhere in the neighborhood of 210,000 tests per day, and up from, again, as I mentioned, only a couple of hundred per day in the early days when it was a completely manual process. But we've applied a tremendous amount of automation, robotics, and other process improvements, both scientifically on the assay itself, as well as all of the things that it takes to get the specimens into our equipment to try to help the country and world address the situation.
No, that's great, Brian. And I think, you hit on a bunch of the challenges that come up with this. I guess one of the points you made was you had capacity, but of course that capacity was allocated elsewhere, given that you are a business and focused on kind of utilization. Can you talk a little bit about how you have thought about scaling your capacity, knowing that eventually we'll be on the other side of COVID, and so you have to kind of strike a balance there, or think about what it all means, I suppose.
Absolutely. We're a publicly traded company and have to be very responsible with our resources. But, kudos go completely to our CEO, who, in working daily with the coronavirus task force at the White House, with the CDC, the NIH, the FDA, we actually went to our board and made a decision. we are going to spare no expense. We're going to call all of the equipment manufacturers, which is a very, very, very global supply chain that we could get into if you'd like, and basically tried to order every available piece of equipment, consumables, supplies, reagents, you name it, across the board so that we could scale up as we foresaw a probable significant increase in cases and therefore the need for testing. So we basically put an APB out for the entire world for every possible way that we could scale up testing. Another important, I would say, business or strategic decision we made very early on, even though we typically are a very standardized platform and try to go to one manufacturer, one vendor, one software, so we can really calibrate every test very precisely across the entire country, we decided very early on that there were likely to be global supply chain challenges. And therefore, we have brought up eight different platforms or different ways of performing the diagnostic testing using each of the major manufacturers around the world and in other parts of that supply chain, so that as inevitable problems arose or supply chain squeezes occurred, we may not be able to hit full capacity, but at least we wouldn't be shut down. We could still divert or use these other platforms to get as much testing done as we could for our customers, which our customers in general are the physicians and hospitals of the US.
Yeah, and so, I mean, that's the global supply chain piece is an interesting one that I think, you know, as an operations professor, I spend a lot of time thinking about it. I think the average person has suddenly seen it go up dramatically in interest, you know, and one that obviously LabCorp spends a lot of time thinking about on a daily basis. So could you talk a bit around kind of those challenges, you know, how you've worked to overcome them, and do you think that reshapes LabCorp's approach going forward?
Sure. As you know very well from some of your research, Brad, the life sciences industry is a very global one. And it's not just a cost play like you might see in some other areas of technology or consumer goods. It's truly about diverse innovation, science, research, R&D done around the world. And some of the largest and most well-known life sciences companies that build the laboratory equipment for the world are not based in America. Companies like Roche Diagnostics, Thermo Fisher, Siemens, these are among the absolute best, highest quality, well-run companies in the world. They're not based in America, or many of the manufacturing operations are not here in the States. And so it was a tremendous challenge in the early days because, as you remember, the political ramifications in the very early days involved closing down the borders for consumer travel, but also very importantly, business travel. And so there were many, I'll say challenging conversations with our federal government representatives saying, but we have millions of dollars of equipment and supplies sitting in customs in the New York harbor or the San Francisco harbor that we have got to get to our labs in order to scale up our capacity. Can you please help us and put politics aside and do what you need to do to inspect the goods and make sure that we can quickly get it to our laboratories? And I would say they were incredibly flexible and collaborative in making that happen, knowing that the spotlight was on getting that done. But most of those goods were coming from abroad. And I mean, one very simple one, which was well written in the New York Times and Wall Street Journal in the very early days. No one in the history of medicine has ever really cared or thought about swabs before. It's just not, even doctors could care less, right? They just give me a swab that works for your test and I'm going to use it on the patient and send it in. Well, most influenza and other difficult to find respiratory viruses use something called a nasopharyngeal swab, which there were all sorts of characterizations, unfortunately, early on about how deep the swab needs to be put into a person's nasal cavity in order to get a really good quality specimen. Well, who would have known, frankly, or cared before March that probably 2/3 of the entire world's supply of those come from one really good factory about 12 miles east of Milan, Italy. And if you'll remember, one of the very first places that had the worst caseload outside of China in the very beginning was Milan, Italy. And that massively shut down or limited supply coming out of that factory, of course, in the early days. And that's the very simple, cheap thing needed to massively scale up capacity in the early days. So while it was a crisis for a very short period of time and led to a lot of conversations with our federal government, a couple of things happened. That same company actually very quickly and amazingly efficiently opened a factory in Puerto Rico to be able to crank out tens of thousands of those per day that we were able to get within just a couple of weeks of the Milan situation happening. That was amazing. And then we also turned a completely separate group of our R&D team into working every single day with the FDA to say, how can we carefully and accurately get these specimens from patients using anything else besides that? And we were able to eventually get up to dozens of different swab types, formulations that had been used for other things and were, medical grade, sterile, et cetera. But we were able to validate them with the positive specimens that we had, show all of that data to the FDA, and then enable us to massively expand the ways in which doctors and nurses were able to collect the specimens. And that wasn't written about much back in, call it April, but that was incredibly important to our country to enable doctors to be able to get more specimens on their patients. And then, similarly, there are other liquid solutions where you put the swab into for transportation back to the laboratory, and you have to maintain the integrity of the cells in there so that the specimen is still in good shape, and then we can find the virus once we do the actual testing in the laboratory. And we were able to expand from a very specific type of liquid that was originally used to then validate the ability of saline to also preserve the virus under the right temperature conditions for a short period of time to get those to the nation's laboratories. And that's been an unsung but unbelievably important scientific innovation, which again is not going to sound very hard to anybody, but requires doing the very fast studies necessary to convince the FDA and other scientists of the validity and the correlation between these different positive specimens and these different ways of doing it. And most other labs have been able to pick up on these many different methodologies for getting the specimens transported.
No, and Brandon, that's great to hear. And I think I want to come back later, but this idea of radical kind of incrementalism has come up repeatedly this morning. And I think it's, at least to me, a theme worth diving into a little bit more. But before that, do you think that will this change how the industry more broadly approaches supply chains? Will we see more nearshoring? Will we see more suppliers rather than sole source, things like that?
Maybe. This, I would like to maybe talk about it again in 2 years when we can look back and say, what would we do now? Is this another once per 100-year event? And I would say the border restriction thing, while it makes it seem like we should onshore lots and lots of different things, I'll say this, we're just coming on the back end of hurricane season. And we have many, many, many facilities in Puerto Rico, in Florida, and the Gulf Shore area in Houston, where we're always closing down and rerouting specimens from one lab to another, or closing down our patient service centers where you get your blood or urine collected. And so there's no simple solution of just because it's on American soil, it is going to magically always be in operation and economic and feasible to do. I think the key is not necessarily where it's located, but having some redundancy. So we have over 5,000 tests on our menu. Some of them are insanely esoteric things that require unbelievably expensive equipment and people to do them. And they're for very rare diseases, so not very often done. But yet our goal is to not have any of them be only able to be conducted in one building. In case there is a hurricane, an earthquake, a tornado, a power outage, or anything else, we need to be able to get that test done for a patient anywhere. And so geography is one of many, many different things. And certainly the political ramifications of the border restrictions was critically important back in February, March. I would say dramatically less so now, even though the virus is still raging everywhere. Most countries and companies realize the necessity of moving goods where they need to be moved. We know a lot more now about protecting the workers that are doing the transport. There's less of a supply squeeze around the PPE than there was in the very early days. And there's a lot more thought put into how to do that carefully. So it's possible that there is more onshoring in the future. I don't know that that is something where you check the box and say, okay, now we've solved the supply chain issue forevermore. I think it's dramatically more complicated than that. And then even if you get to that stable, steady state, you do have to think about the realities of cost and all of the other factors that go into some of these particular issues, as you know so well from your research.
Yep. Yeah, no, it's a great point. And, this challenge of moving, between different different settings, really, of pandemic response to, more standard business operations. Yes, 2 years will be helpful, and then you can be an academic and get to look backwards and just point at it rather than having to live in the moment and make the decisions to survive. So, Brad, I want to, one of the things I was excited about this conversation is that you kind of could spend the first time looking at kind of COVID and testing and making sense of that, given your role, but also kind of you're one of the most diverse, experienced individuals I know in healthcare, and so can try to help us make sense of kind of where we are and where we're going. And so to hit on one of the themes from this morning that has come up quite a bit has been the role of the government in helping shape the direction of healthcare, whether that's through payment models, thinking about drug development, obviously vaccines in our current time. And so, there was an interesting point by one of the leaders in the program saying, hey, in times of crisis, people maybe want the government to do more, provide some guidance, but when things are going better, we want flexibility and maybe less government intervention on the business side. And so, as you run a business such as yours now, how do you have kind of predictable regulatory structures, but also incentives to kind of, drive innovation is a real challenge. And so, I mean, how do you think about this in working with the government, in trying to improve public-private collaborations, collaborations more broadly, knowing that the environment's going to look really different 2 years from now than it does today, than any of us thought it would a year ago, et cetera?
That's such an important topic, and I think will be hotly debated, at least in the first couple of years of the expected Biden administration, I would say. There have been some really good examples of public-private partnership throughout 2020, I believe. I would point to ourselves and say, I think we have an incredibly collaborative and good relationship with the CDC, NIH, FDA, and some of the other health agency authorities in particular. That we're trying very hard to address this. Now, a separate issue I would say is sort of what you got to. The government's role is at least regulatory oversight, for sure. Like, what are the rules? Who's on first? Who's doing what? And then you can figure out how deep or not they go into controlling those factors. But even if I back up one level, and I don't mean this as an overly political statement by any stretch of the words, but more speaking as a physician disappointed in the current state of affairs, I think the government has an incredibly critical role in making sure that the public understands the importance of the use of and transparency around the science that goes into decisions being made. And I mean that in several different ways. One is, again, purely just as a physician being in medicine for 25 years, I can't recall a time when physicians and other scientists around the world didn't look at the CDC and NIH and FDA as the absolute preeminent scientists in their field. You may disagree with, as you pointed out, how far they go in what they regulate or a particular policy decision they make. But I don't remember ever actually questioning the veracity of the science that they were conducting. Makes me very sad that we seem to be in that situation right now. I think it's going to be many different years till we restore that. And I think while we are going to debate vigorously in this country and others, the questions that you raised in your question, I don't know that we're ever going to get to a satisfactory answer and be able to draw that line well, unless we restore just basic trust and confidence in the fact that at least health-based federal health agencies have the interest of the public in mind and are using science to drive and make their decisions. And there are scientists at the helm who have nonpartisan goals of trying to get to the right answer and present that science to policymakers, and then policymakers help answer the specific questions you asked about how much regulatory oversight, how deep do we go? Do we go so far as making price controls or not? Do we tell private enterprise what to do? Many of you know President Trump spoke quite a bit this summer about whether or not he was going to invoke the Defense Production Act and how much. Many of you know that one of the core tenets of the president-elect's specific plan on their website is to invoke that around the manufacturing of the supplies for testing and other aspects of it. That is going to lead to lots of important and vigorous conversations between private enterprise and the incoming administration about what that means. Is it, as you said, creating a regulatory structure and perhaps the right financial incentives for industry to scale up and meet the needs of the country and world? Or is it literally a more involved intercalation into the companies to actually make decisions for the company with the company? And that's an important conversation to have, and to what ends. And does, in general, do the government agencies in a time of transition have the expertise to make those decisions, or is it really more about oversight and incentives?
So I have two directions I want to go. Let's go the politics direction first, and then I want to talk about kind of the market failure, point that was underneath what you were just saying. So, I mean, just to push a little bit more on the politics side, the past 4 years have certainly, highlighted the polarization, and we've seen it before then too, likely to see it going forward. How does one manage in these times where we know there'll be there are likely to be two different administrations here, and so, people will disagree with one or the other. How do you actually get things done, as a business leader, where you have to work tightly with government and you may fundamentally disagree with at least some of the messaging of what they're doing?
That's such an important question, and maybe this sounds trite, but I truly believe it. I know everybody at my company believes it, and most of the other companies that we work with every day is, at LabCorp and other companies, we're not taking sides. I guess we're taking the side of our customer and the patients who are looking to us for testing. We're going to work with whoever is in charge of whatever committee or whatever task force or whatever government agency. We're absolutely going to collaborate with them, be open and transparent with them, and try to get the work done. I hope the transition is relatively smooth and balls don't get dropped in the middle. I could envision us speaking to both teams over the next couple of months, if necessary, to make sure that everybody is up to speed on what's actually happening in the industry and the trends that we're seeing, the utilization patterns that we have, what our customers are asking for, our capacity and demand, all of those important issues.
Fair enough. Let's kind of pull it kind of a little bit wider. And you were talking about some of these challenges that we certainly face, and then thinking about kind of how the system responds. So as we look at healthcare broadly, there are a number of different market failures that have occurred over the last handful of years, whether that's the opioid crisis or Martin Shkreli or some of the inflated billing we see. How do we think about as a system addressing these failures, and how can business be a part of that? Or is something like a single-payer system the inevitable outcome?
I don't know that it's an inevitable outcome, or it may be an inevitable outcome, but the timeline is perhaps glacial in this country. I'm not sure. But there's so many different aspects to that overall piece. most companies are self-insured, and so they're thinking about it not just from participating within the healthcare economy, but also the costs that they're seeing on their side. I would say, again, most of our customers are providers within the healthcare industry across the country and in other parts of the world, and they certainly have experienced some pretty significant pain this year, partly due to patient unwillingness to expose themselves in the time of uncertainty, partly because of the healthcare institutions themselves taking appropriate measures to protect its own workforce, partly because of some of the either mandates or suggestions of public health authorities to limit elective procedures or non-urgent procedures in the early days. And we know that even though everyone would agree that the overall total cost of healthcare is too much, every dollar spent within healthcare is some healthcare provider's revenue. And we've seen just an incredibly painful year for many of our customers, doctors' practices, physicians' offices, hospitals, health systems, other types of institutions around the country, that could take them a long time to recover from this. I would perhaps caution that looking at this as though this is the new normal and applying a policy solution because it would have potentially helped in 2020 is probably not the lens that hindsight will apply to it in years to come. As we all know, it's dramatically more complicated than just coming up with a silver bullet policy solution. There are tremendous stakeholder interests in healthcare. It's 18% of the GDP, and that represents an enormous number of people who all stand to be changed, if not win or lose in any policy solution that comes. I think given what we think as of today, at least, probably some sort of a divided federal government makes it less likely to have a significant change, at least during the next 2, if not 4 years. And, just on Tuesday of this week, the Supreme Court heard the latest in a series of cases around the constitutionality of aspects of the Affordable Care Act. Assuming that stands, I would think that there are thousands of potential incremental improvements that could be made in the current state of affairs in the country at the state and federal level. That's more likely to be on the table rather than major overhauls, I would think, in the short term. And personally, I'm okay with that because I think most things need to be addressed expecting small wins in a lot of different categories rather than 1 or 2 major signature changes that we all magically believe is going to, quote, fix the system. And I just don't think that that's in the cards.
Yeah, I want to highlight. I mean, one of the points you made, and it's a line I quote you on often, is that one person's waste is another person's revenue, and recognizing kind of the duality there as we think about change. And it's not that parties are not impacted as we take that money away. Somebody's going to feel it, and we have to think that through.
Give you one example on that. Since you work there now, I worked at UNC-Chapel before. It's an amazing place, incredibly talented doctors, nurses, and others that all want to do the right thing. There's not one person who gets a bill from UNC-Chapel and thinks it's too low and they should charge more and that it's a great price. But yet probably not many people don't think that it's a fantastic institution where you get really top quality care. That's the fundamental problem that you raise of, UNC, I'm sure, was very negatively impacted during 2020 because of the loss of all of the elective orthopedic and other procedures that frankly drive the financials of an important health system like UNC that does so much good work, uncompensated work, and low cost work for the underserved communities. So we have to balance out all of those factors. And again, that's why I think responding just to what potentially could have helped in 2020 is probably not what's going to save the system or improve the system long term.
Well, and it's a theme that came up lightly today, but I think it's always worth pulling out. Is we have a healthcare system that relies kind of quite significantly on cross-subsidization, and so making money in one place to handle indigent care in another is an example, and certainly relevant to your UNC piece as a hospital of last resort in the state. And so it ties then to kind of my next question theme around incentives and metrics came up over and over again, that we need to improve them to get kind of not only better access but better outcomes. And so can you kind of offer comments on how do you see kind of those incentives metrics moving in a direction for maybe a better health system?
Absolutely, and I still have quite a few battle scars from trying to do that while working at a major payer for several years, trying to incent doctors, hospitals, and others in the healthcare system to improve the outcome of the care that they were delivering. Several problems with that are obviously the healthcare itself and the things within the direct control of the healthcare provider is only one small subset of what actually drives the outcomes, as we all know. The other problem, though, that is probably, in my opinion, not talked about enough is we really don't have a good enough set of quality metrics that actually help show the world what a good quality outcome is. Doctors and even the CMS nationally state very clearly that we have metric fatigue, if you will. There are thousands of different things we could measure people on. We're not really sure yet if they matter to the patient and to the doctor and to the system overall yet. So we need a whole lot more work on even what we're measuring and how. Make it within the workflow of them so it's not extra administrative burden to even measure the stuff that we say matters. And then have the financial incentives actually be enough to get their attention and make it worth the while of doing the extra work or the change in work or whatever it is to get it. While again, everybody has that same goal of improving outcomes, there's no crystal clear path to actually measuring it or getting there.
And I think it's a great point that value as a concept, I think most of us can rally around once we try to turn it into tactical measures. Progress has been made, but it's far more difficult to actually pull it off.
That's right.
So please, to the extent you have questions, put them in the Q&A. We'll continue to weave them in. Kind of one of the things that has come up quite a bit today is around connectedness, kind of ecosystems. And as we think about ecosystems, part of the story there definitionally is it is kind of interconnection, right? Interacting. But it's also thinking about kind of how folks collaborate, right? And move not only from, we're touching, we're connected, but we're actually doing things together. And so can you kind of comment on how can the healthcare ecosystem move into that true collaboration that we'd like to see?
There are so many different examples from this year. I hope that trend continues. I mean, in my little industry, the lab industry, there are thousands and thousands of different labs across the country, but there are two really major national ones, LabCorp and Quest Diagnostics. And given the nature of the crisis this year, I actually have the chief medical officer of Quest on speed dial. We've written a couple of papers together this year. We're probably going to talk this weekend about another situation we're dealing with in the supply chain. And we're fierce competitors in our day jobs pre-COVID, but you have to rise above the occasion. You have to do what's right for the industry and for our customers and for patients. And I hope those kinds of, or at least that theme or that willingness continues in the future, just like the public-private partnerships. The number of unbelievably raw and transparent conversations that we have had with our very regulators this year has been amazing, frankly, inspirational. And I hope in the same way, I hope that level of sharing, trust, flexibility, collaboration continues into the future, even when we get back to normal times, because it's helped us solve issues, share information, and get ahead of problems we all foresaw in the future massively faster than the traditional processes otherwise would have allowed.
And let me kind of push you on that for a second, which is, yes, necessity is the mother of invention, but and we'd like to see things change, but how likely do you think we really get long-lasting change in healthcare as a result of all of these responses to COVID?
Long-lasting changes in the general healthcare system, probably not that many, as most people yearn to get back to some semblance of normalcy. Now, could we see more provider consolidation because of the financial impairment that's taken place this year? Probably. Are we going to see more value-based care contracts because many of the physicians who lost so much revenue during the middle part of the year would like a little bit more predictability in their budgeting? Perhaps. But I don't know that we're going to see wholesale change as a result of what happened this year. I think everybody is going to optimize their current situation and try to succeed in the future, just like they did before they ever heard the word COVID.
So a follow-up from the audience from David Ballard on that one, saying that COVID has reduced, the questions, the words appropriate but unnecessary care. And do you see this more conservative practice style surviving COVID?
I'll put my old payer hat on and say, I hope so. And here's what I mean by that. There has been a lot less care taken place this year. There is lots of discussion among the consulting community over whether it's pent-up demand that will reappear or whether it will simply go away and not come back. If this had been a 6-week affair, I think it would have not changed the minds and hearts of patients and consumers who, as we all know, do get a fair amount of discretionary and potentially unnecessary care in normal years. If this is a reminder of many people that there is an inherent risk, perhaps, to going to healthcare facilities and potentially catching COVID, it might slightly increase the threshold of what you believe is something that you should seek care. Now, we have way more channels, including a massive expansion of telehealth that happened this year if the reimbursement changes stay in place. But I think it is likely, Brad, to not for consumer demand for healthcare to not necessarily return to pre-pandemic levels, but perhaps to have a slightly higher threshold that while painful for the providers that were enjoying the benefits of that extra volume and revenue, is definitely good for the health system overall, helps address some of the shortages that existed pre-pandemic, and is just a reset in the minds of what the appropriate use of the healthcare system may be versus other opportunities to address social determinants of health and other issues that might not most appropriately be addressed within the healthcare system proper. And I think that would be a positive change.
That's great. You mentioned in kind of your prior answer another thing around consolidation, and that we may see kind of financial distress as a driver of consolidation. And over the last few years, certainly consolidation, vertical integration have both been big themes. And I'm curious, given that you've sat in a number of different roles, are these things good or bad for the industry?
As you know well, the research is quite mixed on that. It's hard to find overwhelming evidence that in particular hospital and health system consolidation delivers lower consumer costs. It certainly can create important operating efficiencies for the entities that combine. But to the degree that that is shared by and manifest to the payer community and the patient community, the evidence is a bit scant on that. And the same in other parts of the healthcare system as well. I think that's another example where having very clear guidelines on what the regulatory expectations are in antitrust reviews is potentially important. As many of the viewers know, there were some pretty significant health insurance mergers that were blocked for antitrust purposes a few years ago. But it's pretty rare for large healthcare provider consolidation to get blocked on antitrust purposes. And so I think that's just an important factor to keep in mind. We'll see what the new administration set point is on that. But part of the issue is the technology that we all know is going to improve and revolutionize healthcare over the long term is, at least currently, incredibly expensive. We cannot continue to expect a 3-doctor family medicine practice in rural North Carolina to put in a massively complicated electronic medical record system, an analytics platform, a value-based care, modernization platform on the revenue of 3 docs, mostly seeing Medicaid patients. That's not reasonable or feasible. So either the cost of the technology it requires to be a successful doctor in these new contractual environments has to come down massively, or we're likely to continue to see a wave of consolidation as the only feasible way that they're going to get access to the tools that the big systems have.
And kind of why, so to your point, just for the broader audience, I'm curious to hear your take on, there are operational efficiency gains, but those don't make it to the end consumer. Why not in healthcare when we see that play out in so many other industries?
And I didn't mean that as pointing fingers at the systems that have gone through that consolidation, because as you know very well,
Sure.
They tend to operate in an insanely low margin environment already. And the operating efficiencies gained might only be sufficient to cover the merit increases of the large number of staff they have to actually run the operation in the beginning. So I think it's more of a longer term economic and operational problem. Everyone knows healthcare, as much or more than just about any other industry, is an incredibly both capital intensive and especially labor intensive business. I mean, boy, does this hit home for me. Not only have we spent, well over $100 million this year at LabCorp just on the extra equipment and stuff it takes to do the testing increase that we've done, but we've actually hired thousands of people around the country. If you think about the specimen collection, the logistics and transport, getting these from every community in America to our network of right now 21 labs doing COVID testing, and the huge number of staff that it takes to manually process the specimens, get them into the computer, put them on the machines, do the reporting on the back end, make sure all of the IT that does the reporting to every state health agency and the CDC is in place. It takes a huge number of people. We've automated a lot of the processes of the specimen work, but everything else that it takes trained humans that have to show up and wear PPE and put themselves in a potentially risky situation in order to conduct these tests. And that just highlights another example of, while we expect a continued wave of technology and modernization in healthcare, I suspect at least during the rest of most of our careers, it will continue to be an incredibly human experience to receive good quality healthcare and to deliver it while we're working around the edges to automate significant parts of it. But people are expensive and they consume lots of healthcare themselves, and they expect raises every year. And we just have to figure out how to manage through that and do the best we can and create the most efficient healthcare system we can.
Thanks, Bren. So I want to turn to a comment that Ruth Christopolsky made in the social determinants panel. And so they're kind of a great exploration of the broader kind of set of drivers of health, as we've been talking really about throughout, as well as some fundamental problems we have due to structural racism. And one of her remarks was, let's do the right thing for our patients and our communities. And if we do that, we'll figure out how to pay for it later. But doing the right thing is important. And so I'm curious kind of, how you think about it, given the many roles that you have held, as well as how do we live into that sort of remark?
Ruth and her team have been doing great work at Atrium under tough conditions down in the greater Charlotte community. So she's truly an expert in this area. I'll give you maybe a general view and then a lab specific view. From a general view, that's mostly a reflection of the types of jobs that people have and whether or not those jobs come with employer-sponsored health insurance, and the makeup of many of the uninsured and underinsured people of the country tend to be overrepresented in the minority populations. And so that's just a very stark reality that, frankly, our country's never adequately addressed. And many states, North Carolina included, haven't expanded Medicaid to be able to provide further insurance access to some of those communities that might otherwise benefit from basic and more advanced healthcare. while most people on this are focused in the healthcare system, perhaps a controversial statement would be, because we all know social determinants of health are so important, and we know we're pouring trillions of dollars into the healthcare system. I think many other countries that have good quality of life outcomes have demonstrated to us that it could potentially be a better net for our country if we would take a whole lot of the money out of the healthcare system proper and put it into a variety of social services that tend to be dramatically more efficient and lower cost, and perhaps more closely related to what people actually need to live the lives that they would like to live. Just one very specific example within just the lab world, just for COVID, given this very stark reality of how many uninsured and underinsured people there are in the country, particularly those working in frontline service jobs. We were very privileged to work with the CDC and others for most of the things that you saw in the media many months ago around the meat packing plants, some of our military bases, some of the other situations where we had early outbreaks. We were fortunate to work with the federal and state governments to do most of the testing in some of those areas. And then once the CARES Act and the Families First Act were passed, it enabled some wonderful access where people, even if they were uninsured, were still able to get the coronavirus testing from their doctor or from other places without any cost whatsoever. So it didn't disincentivize anybody from getting appropriately tested. Now, we had completely separate employment situations where people didn't want to be tested because if they were positive, they knew they weren't going to be able to go to work and make their paycheck. But at least people were able to get access to some of the care they needed through that. Other simple examples are we do a lot of the back end lab testing for the CVS and Walgreens drive-through or walk-through sites that you have. And in our specific agreements with them, we were trying to very specifically target those retail pharmacy stores that tended to be in the underrepresented areas of the country that had higher background prevalence rates, and also were more likely to have many of the workers in the frontline service industries that we most needed to protect given the scarce resources we had. And again, because of the federal funds available through the CARES Act, that enabled those decisions made by companies specifically targeting the underrepresented communities where the need was the greatest, because the incentives were put in place to enable us to do that. In my view, anyway, that was a very, very positive outcome of public-private partnership to target and direct incentives to specifically address one of the manifestations of social determinants of health in particular communities of need.
Yeah, that's great. Great arc there, and a nice one, I think, to end on. Kind of just last question as we wrap, Brian. Kind of give us one reason for hope and optimism as we look forward. Besides the fact that we're almost out of 2020, so only six and a half weeks or so to go.
There is always reason for hope and optimism when you mix science, technology, and people who mean well and want the world to be a better place. I have nothing but optimism that we'll get through the current situation. We're going to learn a tremendous number of things. We're going to make a lot of mistakes in the policies that we make, both privately and publicly at the state and federal level. But I think most people's hearts and minds are in the right place. And again, science and innovation will drive us forward. So we will be in a better place once we get behind this. The vaccines look incredibly promising. If you look at the Pfizer and Moderna data, we're blessed to be involved in many of those trials at LabCorp. And we're very hopeful that that is going to be an incredibly important part of our public health infrastructure in 2021. And we just all have to figure out how to work together, collaborate, inform our policymakers, and make sure that we're thinking of every stakeholder that we can across the system so we can try to just get a little bit better each day.
Awesome. Thank you, Brian. And thank you, everyone, for joining us for the Dean Speaker Series with Dr. Brian Caveney. We'll now move into our last session of the day, the final round of the UNC Healthcare Case Competition. To attend this session, just please stay in this webinar room. We'll be back in 5 minutes to kick things off. Thanks, everybody. Appreciate it.